Hi, welcome everyone. Today we will be discussing about renal tubular acidosis, which is a group of disorders characterized by impaired renal acid base handling. We will go through its causes, types, diagnostic investigations, and management plan. So, first of all, how to define renal tubular acidosis? It refers to a condition where the kidneys fail to acidify urine properly, leading to a buildup of acid in the blood. Importantly, the anion gap remains normal, distinguishing it from other causes of metabolic acidosis. So, this picture is showing the definition of renal tubular acidosis. There is hyperkalemic metabolic acidosis with normal anion gap, and pathology involves defective bicarbonate reabsorption in the proximal convoluted tubules, suppressed renal ammoniogenesis, and inadequate distal tubule proton secretion. All these abnormalities lead to acidosis. How to classify or what are the types of renal tubular acidosis? The renal tubular acidosis mainly characterized by three main types. Type 1 is also known as distal renal tubular acidosis, which involves distal tubules inability to secrete hydrogen ions. Type 2 is proximal renal tubular acidosis resulting from proximal tubule failure to reabsorb bicarbonate. And type 4 is type 4 is hyperkalemic renal tubular acidosis. It is due to hypoaldosteronism or aldosterone resistance leading to hyperkalemia. First of all, we will discuss about type 1 distal renal tubular acidosis. Here in this type, the distal nephron cannot excrete hydrogen ions, so the urine remains alkaline despite systemic acidosis. Hypokalemia is frequent. Common causes include autoimmune conditions like Sjogren's syndrome or systemic lupus erythematosus (SLE), and certain drugs like amphotericin B, which is systemic antifungal drug. Because of the high urine pH, calcium stones are a common complication of type 1 distal renal tubular acidosis. So here you can see all demonstration of distal renal tubular acidosis, which shows it is a defect in decreased distal hydrogen secretion. No new bicarbonate is generated, and there are various causes enlisted for type 1 distal renal tubular acidosis like amphotericin B, toxicity, analgesic nephropathy, autoimmune disorders, and urinary tract obstruction, and various signs symptoms of these causes are also listed there. Urinary pH is always more than 5.5, and bicarbonate level is 10 to 15 millimole per liter. Potassium level is decreased. Hypokalemia is always there, and how you will diagnose those tests are also mentioned, and we will discuss about treatment in later stages. Second one is type 2 proximal renal tubular acidosis. In proximal renal tubular acidosis, the proximal tubule fails to reabsorb bicarbonate efficiently. Initially, urine is alkaline, but as plasma bicarbonate falls, urine becomes acidic. It is commonly seen in Fanconi's syndrome or after carbonic anhydrase inhibitor therapy. As you can see here, what is the primary defect in proximal renal tubular type 2 acidosis? It is decreased proximal bicarbonate reabsorption. Causes are enlisted there. Their sign symptoms also listed there. Urinary pH if, more than 7 if plasma bicarbonate is normal, and pH is less than 5.5 if plasma bicarbonate is depleted. And hypokalemia is also seen here. For diagnosis, we will do bicarbonate loading test, and treatment we will discuss later on. Type 4 hyperkalemic renal tubular acidosis. Type 4 acidosis results from impaired aldosterone secretion or action, reducing ammonium excretion. The hallmark is hyperkalemia here. As you have seen that in previous first two types there is hypokalemia present, but hallmark of type 4 is hyperkalemia, and it is frequently seen in diabetic nephropathy or with drugs like angiotensin converting enzyme inhibitors or angiotensin receptor blockers. So you can see here what is the defect in hyperkalemic type 4 renal tubular acidosis. There is aldosterone deficiency or aldosterone resistance leading to hyperkalemia and reduced ammonium excretion. Causes are enlisted there. Sign symptoms you can see here. What are the manifestations of hyperkalemia? And severe hyperkalemia, cardiac arrhythmias can occur. Urinary pH is less than 5.5 and potassium level is increased, causing hyperkalemia, and bicarbonate level is more than 17 millimole per liter. So this table enlists comparison between these three types of renal tubular acidosis with their causes also and with their treatment enlisted below. This picture is showing how shows you how to do the metabolic workup and how you will assess the proximal tubular function. If there is metabolic acidosis, assess proximal tubular function. If there is abnormal proximal tubular function, it is proximal type 2 renal tubular acidosis diagnosis. If there is normal proximal tubular function, then measure potassium level. If potassium level is increased, this is type 4 renal tubular acidosis. If potassium level is normal or low, it will be either hypokalemic type 1 or secondly renal tubular acidosis of renal insufficiency. Investigations. Diagnosis begins with identifying a normal anion gap metabolic acidosis on arterial blood gas. Potassium levels helps to differentiate the types. Urine pH is crucial. A highly persistent urine pH suggests distal renal tubular acidosis. The urine anion gap helps to estimate ammonium excretion, and imaging may detect nephrocalcinosis. Here are the investigations that differentiate between various types of renal tubular acidosis. As you can see that in proximal renal tubular acidosis, there is normal or low potassium level. In distal, also potassium level is low. In type 4 is hyperkalemic. You can compare the bicarbonate levels of three types. You can compare the urinary pH less than 5.3, it is proximal renal tubular acidosis. pH more than 5.3 distal, less than 5.3 type 4. And you can also see urinary anion gap is positive in both three types. Nephrocalcinosis only present in type 2 distal renal tubular acidosis, and rickets is common in proximal renal tubular acidosis and usually present in distal renal tubular acidosis and absent in type 4. So treatment overview. Treatment mainly focuses on correcting metabolic acidosis and addressing the underlying defect. If type 1 is managed with bicarbonate and potassium supplements, type 2 needs larger bicarbonate doses, often combined with thiazide diuretics to reduce the bicarbonate loss. Type 4 is treated with fludrocortisone if hypoaldosteronism is present, or with diuretics to lower the potassium levels. To summarize, renal tubular acidosis, it represents a group of tubular disorders causing normal anion gap acidosis. Differentiating the types is essential for targeted therapy. Prompt recognition and correction of acidosis prevent complications like bone diseases and nephrocalcinosis. So in the end, it is very easy to compare both three types. As you can see, in distal renal tubular acidosis, there is defect in hydrogen ion secretion. In type 2 proximal renal tubular acidosis, there is decreased bicarbonate reabsorption, and type 4 is showing is caused by aldosterone deficiency or resistance. First two types, hypokalemia is common, and last one type is hyperkalemia is common. And treatment is also enlisted here. You can see that with distal type 1, you will give sodium bicarbonate or potassium citrate and thiazide diuretics. For type 2, sodium bicarbonate or potassium citrate and thiazide diuretics. And for hyperkalemic type 4, you will use volume expansion, give dietary potassium restriction, and use potassium wasting diuretics. So thank you very much for listening my lecture attentively. We will meet very soon in another lecture. Until that time, good luck to all of you. Thank you very much.